Start recording, and then I will share my screen and we will get going. So if you wouldn't mind just introducing yourself in the chat, that would be amazing. Okay, there we go. So again, welcome to today's Health Council chat. So we'll be hearing from the New Mexico Caregivers Coalition, and we have Sharon here joining us, who is one of their fantastic board members. And then we have New Mexico Department of Health Child Fatality Review with Lisa, who is their coordinator, and Carrie, who is the unit manager. Start with our land acknowledgement. The New Mexico Alliance of Health Councils gives sincere gratitude for the opportunity to live and work here on ancestral and unceded lands that have been cared for by our state's original peoples of the Apache Nations, Pueblos, and the Navajo Nation. We honor and respect the indigenous cultures, traditions, languages, and the rich contributions that continue to shape New Mexico. Together, we acknowledge the history and impact of genocide, dispossession, colonization, and ongoing systemic inequities on Indigenous communities. As a collective, we commit ourselves to working toward justice and reconciliation, dismantling inequitable systems, standing in solidarity with and respecting relationships with Indigenous peoples. The Alliance affirms Indigenous sovereignty, self-determination, and self-governance of New Mexico's tribes, pueblos, and nations. In offering this land acknowledgement, we encourage you all to reflect on your own relationships to traditional lands and take concrete action to dismantle systems of oppression where Indigenous peoples are empowered and celebrated. So just a few things to start off. With updates, we have our comprehensive survey that is due today. And as a thank you for spending your time completing this survey, we're offering a $50 gift card, which will come into your inbox. So if you have any questions, feel free to email me or Geraldine. Any membership agreement questions, you can contact Geraldine. We have our upcoming community collaborative forum. Everybody is welcome to join us. It will be virtual, half day on Wednesday the 20th. And we have a nice little easy link to remember where to register. So again, we would invite you to join us. It'll kind of be a continuation of the last one in May, learn a little bit more about SB3 and our state agencies that are collaboratively working and their plans for the future. The statewide meeting and public health day, we'll begin planning that in September. So you will see an invitation for that. And then I promise I'll be done soon. Testimonials would be really incredible just to help with advocacy efforts from yourself, partners, community members. Any videos, please feel free to send to me. And then we also have a nice little form we put together. So you can share it in newsletters or emails to make it a little bit easier for the community to share their stories professionally or as community members. And then we have coming up our QPR training in the middle of August. It's an hour-and-a-half training, complimentary for health councils. You just attend one session and you'll be completely certified in QPR. So whichever one works best, you can join at this link and choose the date that works best for you. Finally, we have a few advocacy updates. Geraldine, I don't see Val here, so I don't know if you would like to chime in.
I'm right here, Sam.
Oh, there you are. I didn't see you. Hi.
Happy Friday, everyone. So great to see you all, be here with all of you. Sharon, so great to see you again. All right, my dear friends, we are in the midst of the interim session and just want to acknowledge once again, everyone, health councils, our advocacy partners, community members. Daryl's here too from Be Well. Welcome. Big advocate of health councils, and just acknowledging everyone's collective effort, unified voice in calling upon our legislators to invest in health councils. And so for the second year in a row, we were able to ensure a one-time state funding allocation, and this year at $4 million, as you all may know. I know health councils are in the process of going over their scope of work with DOH. Know the Alliance is here to be of support to you. And so, as you know, we're leading year-round advocacy efforts to secure recurring optimal funding in support of all the meaningful work that you lead across counties and our tribal communities. And so we have two exciting updates today. I got word from Legislative Finance Committee. We've been petitioning them to include funding for health councils in their LFC priorities. And I got word that funding for health councils has been included in the LFC work plan. And so stay tuned, my friends. This is part of why we continue to reach out to all of you, health councils, community members, advocacy partners, to please join our advocacy efforts, emailing or calling members of Legislative Finance Committee, particularly Representative Small, who's the chair, Senator Munoz, who's the vice chair, and share why it's so critical to invest in county and tribal health councils. Your own personal story, your own success story around the work that you're doing with health councils, or how your health council has impacted your life, your community. They want to hear from all of you. The Alliance continues on engaging with them weekly, and setting up meetings to share with them on a more aggregate level. Here's the impactful work of health councils in this the end of this fiscal year, FY 2025, which is part of why we have launched the annual survey, because that information that you share with us supports the Alliance in our advocacy efforts in support of all of you, and also informing the core services that we provide you with: technical assistance, professional development, and all of that. But not to get too much into the weeds, please reach out to members of LFC. The second exciting update is that typically the Alliance is the one that's called to give expert testimony during the interim session. And this year, San Miguel County Health Council has been invited to present at the Legislative Health and Human Services Committee next week in Las Vegas. This is something that we've been advocating for, to center the voices of health councils during the legislative session. I know there's been a lot of you who've joined us in co-presenting during the interim session and the legislative session, so thank you. These committee meetings are also accessible via Zoom, their webcast. So we'll be sharing on Monday the link to the Legislative Health and Human Services so that you can join and support San Miguel County Health Council as they present on the meaningful work they're leading in their county. And also, if there's an opportunity to give public comment, that you can make sure your voice is heard. As we send you all the Monday's emails to health councils particularly, we've put together an advocacy toolkit that we have curated in support of all of our advocacy partners, and also to hear from you what is feasible for you in the sense of what you're able to engage with in advocacy activities. Is it emailing? Is it calling? Is it joining us on public comment? Whatever your capacity allows you to, for time and energy, please let us know what you're able to do. It's the more unified that we are, a unified front, the better. And trust me, it works. I think I may have shared this quick little story during the session. I asked one of the aides of Senator Munoz, I said, how do you keep track of, all the advocacy? He showed me this worksheet. And I said, today, what are the top 3 most, advocacy voicings from our communities? And there was one on gun regulation. I can't remember the second legislative priority, but the third most called upon Senator Munoz on the advocacy front was funding health councils. So it works, my friends. the more they hear from all of us as a collective unified voice, the better. So with that, happy to answer any questions or if there are any reflections. And Geraldine has also shared the link to the advocacy page where you will find all of these resources. Thank you so much. Over to you, Sam.
I did remember we have a very quick poll just for the statewide meeting location. If anybody has any feedback on that. So the options are Hotel Santa Fe, where we hosted in 2024, the Santa Fe Hilton, where we hosted last year, and then potentially a new location, which I think we're looking at the Drury Plaza Hotel.
Yes, and
If
the
you wouldn't
Drury
mind.
Plaza Hotel is very central. It's in downtown Santa Fe, walking distance to the Capitol and lots of different places. The only drawback there is that they only have valet parking, but there is an adjacent parking that's independently owned that I'm looking into to see how much it would cost to rent that parking lot for our convening. But yeah, let us know what location you prefer so we can start, pre-planning. Thank you.
I'll just leave it open for maybe like 7 more seconds and then we'll pass it over to our presenters. Okay, thank you, everybody. And I will introduce our first presenter. We have Sharon Finarelli joining us from the New Mexico Caregivers Coalition. She was recently the Director of Community Partnerships for Presbyterian Health Plan, and she also served as the Executive Director for the Alliance. So welcome, Sharon. I will go ahead and pass it over to you.
Oh, thank you so much. I just want to say what a treat it is for me to be here after not hanging out with health councils for a couple of years. And so seeing familiar faces, hearing the great work you're doing, and seeing how you've just moved health councils forward over the past couple of years is just, it makes my heart sing. So this is a treat to share what I have to share with you, but also to just get a little bit of an update about how you're doing. And I just miss you. And seeing your names makes me miss you more.
We miss you too, Sharon. So happy you're here.
But you're doing a great job, and I'm so happy to see health councils are still moving forward, because I think now more than ever, health councils are really important, as so much funding is being lost for social service and health support programs. Having a health council is just so critical. So thank you so much for the work that you all continue to do. You matter more than you ever have, because I know so many people are going to be hurt with Medicaid reductions, and it'll be even more important to look for alternatives. So today, while I get my slides up here, let me see if my share will work. I don't want to try to walk and talk at the same time here. All right. Are you seeing anything yet?
Yes, we see that.
Oh, it's not the slideshow yet. Hold on. There we
There you
go.
go. Perfect.
All right. So this is actually another community resource that you may not be familiar with. I wasn't. And so it's something I could have used when I was caring for my mom as a family caregiver. And so it's a resource that is being developed that is focused on two areas. One is family caregiver relief, but also workforce development. And so I'm going to tell you a little bit about the respite care training and registry program that the New Mexico Caregivers Coalition has. And the Caregivers Coalition may not be familiar to you. It is a statewide organization, and we really focus on advocating for direct caregivers. And that means family caregivers who might be caring for a child with disabilities, or maybe an older adult who needs more support, physical or emotional or mental support, that may not be able to live independently. Or it could be a caregiver that is working in someone's home from an agency. So we know that these are some of our critical care workers and some of the lowest paid workers in our state. And so we advocate for higher wages, better benefits, and better access to funding to support family caregivers. Oops, I think I just went back. There we go. So the coalition is a nonprofit, a 501c3 nonprofit, and we formed our mission from town halls and listening sessions throughout the state. And we realize that caregivers don't really have a voice. They're often struggling to survive between, many of them are on Medicaid because the wages, I think the average wage in New Mexico is around $10 an hour or something like that. But many are making much less than that. Many are getting $10 an hour, but working additional hours that are unpaid. So we've heard from them that they really needed an advocate. So that was a very intentional decision that we wanted to do work around supporting caregivers. And we do that with offering training, direct training to them, and also advocating at the legislature on their behalf, and seeing how we could build a stronger workforce by connecting caregivers and existing health and social services positions. So we'll talk more about that at the CHW conference this fall. Career pathways that involve respite care that starts with caregiving and can move into a more advanced workforce position. What we do now, we go on site to do trainings, and some of the examples of trainings we do for home health agencies or others that ask for it at no charge to the agency are things like infection prevention training, safe transfer, mobility communication skills, financial literacy, navigating Medicare and the Disability Resource Center, respite care provider and training, which is what we're talking about today, and the history of community-based services and workers' rights. So I'm going to skip over the links because I want to get through the main information, give you time if you have questions, and make sure I don't step on our other presenters' time. So, but I would be happy to share the PowerPoint with you at the end if that's helpful to you. So what we're talking about with respite care is trying to create a workforce to relieve family caregivers so that they can take care of their own health by, if you need to have a doctor's appointment and you're caring for a loved one 24/7, how do you do that? Medicaid will pay for some respite care, but if you can't find it, it doesn't do much good. Currently, there are a few different grant-funded respite care programs in addition to Medicaid, but it's fragmented. There's not just one place to go for information other than the Aging and Disability Resource Center and Aging and Long-Term Services. Both have some information on that. This training around respite care that we're doing is a 7-hour course. So for community health workers, that's 7 continuing education credits. If they complete the course, it's at no cost to the learner. It's online, and part of my work is supporting learners. So if you have problems with the software system, if you don't really understand the lesson, some of it has video, some of it is just text, PowerPoint format. And if it's a new concept, then you need help, I help with that. And then help explaining what the registry is and how to get to it, which we're going to talk about today. So first, not everybody knows what respite is about. We don't hear doctors telling us, now be sure that you allow time for respite as a family caregiver with someone, you know, dealing with an aging parent or other family member with disabilities. The focus in the doctor's office is all about the patient. But if the family caregiver never has a break, then that can lead to abuse, neglect, mental health issues, physical health issues. And so it's really critical to plan in breaks and to make sure you have some confidence in the training that people are receiving who might be coming in to take care of your loved one. So respite just means a short break, and short break can mean an hour, a day, a week, 2 weeks. It's what you need. Respite can take place in your home, where you would look at the respite care registry that I'll talk to you about in a little bit, and find somebody that you think is a good match for the person you're taking care of. Invite them into your home, maybe interview them in your home, maybe do a background check, which is another service that we offer at a really low price. So I think it's like $25. You can also provide respite for family caregivers at adult daycare centers, but they're far and few between, especially in rural areas. I don't know of any in rural areas. That may not be true, but they're far and few between. And then residential centers that offer overnight stays. I know there's one that is in development around the Ruidoso area that is talking about doing this. But again, trying to find them and afford them, and if they're even available at all. It's an area that needs a lot of development. Whoops. So well, what didn't show is the slide about what the registry is. So how this works is people go through this respite training. It's a 7-hour training. And let me stop sharing so I can just talk to you. Because I want to just be sure that it's clear what we're talking about. And the respite training is based on national standards, things like how to take care of somebody with a mental disability, dementia, someone with a feeding tube, although what we're talking about with respite is not medical care, but putting food in a feeding tube is not considered medical. So that's within the scope. Talking about what kinds of activities and how to plan. So you're not just babysitting somebody, just walking in there and doing nothing. We give, when people have completed the certification, then the next step is the registry, and it's a statewide registry that's searchable by county, by name, by does this person want to take care of adults or children? And within that registry, they create a profile that is like a resume. So we have someone who's done all kinds of healthcare work, retired nursing and all of that. She has probably 6 pages of information about who she is, the training she's done, experience she's had. And then we have others that are just in high school, haven't graduated yet, because we have a few high schools around the state who offer this as part of their, it's like a health tech education program that students take. And so if you're working for an agency providing respite care, then you're required to be 18. But for a private hire, that requirement is not in place. I think it's 16. So we have high schools that we're working with. We have CHWs, for example, in Taos County. We have the Lions Club, who is really trying to build resources for their community. So they decided to pay for background checks at $25 a person. They're focused on CHWs, and I think it might be focusing on CHRs, because I see a lot of people who speak Navajo that put that in their profile. And then we haven't promoted the registry a lot because we're just building it, but what it will be is everyone who's looking for respite can either see a whole list of everyone in the state who's serving. So if you're on the border of a county like Bernalillo and Valencia, maybe you'd like to just see who's in every county. And then once you get the list of registered respite care providers who have completed the certification training, then you can look at their profiles, see if they fit with the needs that you have, and then you decide if you want to hire them or not. We also have sample employment agreements for either people hiring respite care workers or for respite care workers who complete certification, just to help facilitate the connection, because they negotiate their own salary, they negotiate their own duties unless they're working for an agency. And we have ongoing upgrades to our training that are specific to New Mexico, so that you know what the New Mexico law is before you go into someone's house. So what I'm looking at health councils to do is two things. One, if you know that your county has no respite care workers, which I can give you the registry address and chat after I'm done, or you think you want to help to build that resource. If there is a public school in your county that has a high school, we would love to come and offer that training to that. If it's a health education class or something similar, health technology class. If you have CHWs who might benefit from continuing education units, if you would refer them to us, I would love to talk to them about how this could happen and the support that's available. Or if you have families who are taking care of loved ones, either children with disabilities or older adults, and are looking for a break, I would love to have them referred to us so that they can find some resources. I'm happy to come and talk to any of your health councils. If you have questions, we also have materials that we can send to you. And so I know I'm getting close to 12:30 here, so I want to give you time if you have any questions or comments or suggestions about how we can get the word out, where there might be opportunities for training, or other thoughts about how to connect this resource with the people who need it. I would love to hear from you.
And Sharon, hi, it's Geraldine. So nice to see you.
Good to see you, Geraldine.
I just posted your link to your website in chat, so if anyone wants to look at that. So I just wanted to note that for health councils. And then just maybe a quick follow-up question. At least with tribal communities, has there been a lot of engagement with the coalition?
I see some from the northern part of the state, and like I said, I see the only way I know they're tribal is because when they talk about languages spoken, and I see Navajo, probably they're a tribal member, most likely. So I do see that, and then I'm like 90% sure that Taos is working with Taos Pueblo. I think that's it. Or another tribe, because I don't go out and make those relationships, but just because of seeing that some of the names and some of the languages, that makes me, think that it's CHRs. And of course, we would love to offer more, because I know in many tribal families, there are extended generations, multiple generations in the same household. And so it would probably be really nice if the person who's taking care of the elder could have a break every once in a while, maybe even a scheduled break, especially if there's funding, which this grant that funds the program is through Aging and Long-Term Services, and they get it from federal money, that something for community living. But there's a second part of this grant that does fund the actual care that we have not applied for yet. My understanding is that Aging and Long-Term Services is very interested in building the workforce first, before there is, people searching for respite care workers that don't exist. And how that works in other states are like families get whatever determined amount, like 500 a quarter or 6 months. It goes to the family caregiver, And then they are responsible to hire the respite care worker for whatever time they need within that period of time. So if it's twice a year and it's $500 for every 6 months, they decide, when do they need help and who they choose the person to provide the care. And what they just have to show is that you use that grant funding to pay for respite care. It's not in New Mexico yet. And like I said, I think the first step is building a workforce, making sure there are people available. I'm thrilled that Sierra County, my county, had our first person that is listed on the registry just this morning. So it takes a while because it's not really connected to universities or community, colleges or anything. It's independent. And that's a good thing, but it's also makes getting the word out a little more challenging. So I would love to have any suggestions. I'll put the training link and the registry link and my email in the chat again, just so if you have ideas or questions, I don't want you to feel like this is your one shot, because it's most likely kind of a new concept for most everybody. Okay, well, thank you very much for giving me the opportunity. I hope I didn't tell you too much too fast. And Sam, I'll send this to you so that you can and there are links in it that take you to different places, including a video of people who have gone through the training. I just wanted to be sure that Carrie has all the time he needs today too. So thank you again, and it is a delight to see all of you.
Sharon, this is Anthony. Remember me? Anthony.
I do, Anthony. I didn't see you down there. Got my bifocals on and everything's blurry.
I'm looking on the top of the list. Just wanted to thank you for your presentation. And I'm glad you went to an area where I think we've had recent discussions about respite care and caregivers association and things like that at Santo Domingo. So
Oh,
just
great.
ears open. We got some agenda items that are coming up with the Health Council as well as the New Mexico CHR Association. So thank you. And
Excellent. Well, thank you for that update, Anthony, because I know we want to work with tribal communities and when they're ready, how they want it to connect. And so it's a fine balance to make sure they know we're there and to also be very respectful of what they can do when they can do it. So if you're aware of any needs or any interests that we haven't addressed, we want to hear about it. But again, like every community, they're ready at their own time, and we want to respect that. And it fits in its own place in every community, fits a little bit differently, just like health councils, how they work in every community is just a little bit different. And so we want to be respectful of that too, so that it fits in the best way. So thank you for sharing that, Anthony.
And all these slides, all the contact information will be sent out on Monday along with this recording. So it'll be easy for everybody to access. And then I'll also include it in the Health Council Hub as well. So thank you so much, Sharon. It's been amazing hearing from you and having you here. Let's see it. All right. So now I would like to introduce Lisa and Carrie from the New Mexico Department of Health to tell us about their program.
Thank you, Sam. I'm Lisa Roleader, and I am the coordinator for the Child Fatality Review Program. Just as a segue, though, from Sharon's presentation, I wanted to share that I was a respite provider when I was in college and graduate school, and then I worked in the early intervention field, and I saw the benefit of respite services to families from that angle as well.
So that's great to hear. Oh,
yeah, I really believe in it, so and support it. I'm here today to to talk about the Child Fatality Review Program. And I attended the Alliance's annual meeting in 2025, and I'm still not sure how I ended up on the invitation list, but I was really thrilled to be invited, and I learned a lot when I attended the meeting, especially from the councils who did presentations about the work that they were doing in their communities. So when I started this job, which was just about 2 months ago, right away I thought, oh, I want to connect with the Alliance of Health Councils and with the health councils around the state. I want to check in and make sure that the slides are showing for you guys.
Yes.
Yes.
Oh, excellent. Thank you. So, Child Fatality Review has been around in various forms for a number of years. The first Child Fatality Review program originated in Los Angeles, and it was came about through concerns about the way that child abuse and neglect fatalities were being discussed and talked about and understood, and what kinds of actions were being taken to prevent those kinds of fatalities as well as injuries. The first statewide program was introduced in Missouri in 1990. And then New Mexico, we started our Child Fatality Review Program in 1998. Let me just move the slides along here. And ultimately, the Child Fatality Review comes from a desire to reduce risk factors and protect children and protect communities. The death of a child is associated with profound loss and grief that affects the family, but also ripples out through the community, and can sometimes that impact can last across generations. The death of a child is a sentinel event. It really does call us to action, should mobilize a community to identify other children at risk. And it is a community responsibility. The review itself can often be a very complex process, and it really requires people coming from a lot of different professions and walks of life to come together to understand what happens when a fatality occurs. And as I said, it's really focused on identifying risk and protective factors and focusing on prevention. So a big effort of the review program is to develop recommendations that can be taken forward through various methods to change policy or introduce legislation and really try to reduce those risks or enhance protective factors. And so, as I said, this in New Mexico, this originated in 1998. DOH has the statutory authority to conduct the review of deaths, and the rulemaking is in the New Mexico Administrative Code, and it's 7.4.5. And when you get access to these slides, that link is active, and you can go there and you can kind of see the rules in our state that govern how we do child fatality review. And then I wanted to just share some data with you to kind of give you some grounding in what's happening, really. Oops, sorry about that. So this graph is showing in the whole U.S. the population from 0 to 17, and this is from 1999 to 2020, so a 20-year period basically. The leading causes of child deaths, and you can see that injury is the leading cause, in particular motor vehicle crashes. But I also wanted to note that just within the past 5 years, that firearm-related injury has now surpassed motor vehicle crashes as the leading cause of child death. With the child fatality review, we're really looking at the deaths from non-natural causes. So some of those natural causes of death, malignant neoplasm, cancer, basically, congenital anomalies, chronic respiratory diseases, those deaths associated with those factors are not reviewed. But you can also see that injury far outweighs natural causes of death. And this next slide is looking specifically at New Mexico compared to the US rate of injury deaths overall. This is starting with 2001. So in 1998, that was when New Mexico started the review process, and the numbers kind of grew, the rate of deaths grew, and that could have been due to the fact that the deaths were being reviewed and there was greater attention, maybe better reporting of child fatality due to injury. And then over the next more or less 13, 15 years, 10 years, that the rates were really going down. There were some bumps here and there, but kind of an overall downward trend. But then, looking here, we were really close to the national average. But since then, that trend has gone upward, and our rate of injury deaths has gradually been increasing. And it's really, it peaked in 2023, and that's the most recent year for which the data is available. So there's a lot of work to do in child fatality review to try to reverse that trend. And then here's just a little deeper dive into some of the causes of injury death in our state specifically. And this is pulling out ages 1 to 17 years. The leading cause of death in the birth to age 1 population is suffocation associated with unsafe sleep. So we've pulled that out and then looked at deaths in the population from 1 to 17. And you can see the motor vehicle traffic is a leading cause. But again, if we were to take the firearm deaths that are homicide and then also firearm deaths that are suicides and combine those two, it's 27%. So we are right on trend with the US that firearm-related deaths is now exceeding motor vehicle accidents in our state. And if we also look at suicide and by firearm and suicide by suffocation, that's roughly 1/5 of deaths of young people in our state are suicides. And then just looking at some of the disparities that we see specifically in race and ethnicity, and this is per 100,000 population, and we know that the non-Hispanic Black population and non-Hispanic American Indian Alaska Native populations are smaller population groups, but the burden of child death is and the rate of child death is much higher in those populations. And then there are more male children and youth who are dying from injury. And that's consistent across the US as well. And so, as I was saying, also, like it's the death of a child can be a very complex event. And when we're reviewing fatalities, we really want to look beyond like the individual behaviors that happened in the incident of the death. We want to really expand to think about the contexts in which children and families are living, as well as the context in which injury and death occurs. And so, for example, as it applies to child fatality review, a motor vehicle accident, for example, perhaps there was unsafe driving behavior. But if we expand our lens, we might look at, well, what is the rate of motor vehicle accidents on that road? Does it have something to do with the speed limit on the road or some other factors associated perhaps with the surface of the road? And then, extending the lens even wider, what kind of driver education might be, like changes to the way driver education is done, or public safety information that goes out to communities that could address some of those risk factors. And so the panels are made up of people, as I was saying, from a lot of different professions and affiliations. So there's, of course, public health and the medical community, members of schools, faith-based communities, law enforcement, child protective services, the Office of the Medical Investigator, the judicial system, community-based service providers, people who provide mental and behavioral health to children and families, substance use treatment providers, etc. And we're especially interested in people who come from lots of different communities so that we can get the perspectives of people from all over the state and not just from some like our larger population areas. And this is what the process looks like. So let me just check our time too. Okay, I'm good. And I'll go through this a little bit quickly. I won't touch every point, but the Child Fatality Review Program we receive from the Vital Records Office at DOH monthly submission of death certificates. We process those, and these again are just deaths due to injury for ages 0 through 17. And then we start building a case. And so we are going to be requesting records from the Office of the Medical Investigator, so autopsy and toxicology, etc., law enforcement records, potentially school records. There are some databases that we can access. And we look into social media, again, and obituaries as another source of information. We have 5 different panels that are each topical. And so the CANH is the Child Abuse, Neglect, Homicide panel. We have the suicide panel, and those are sudden unexplained infant deaths. So typically 0 to about 16 months of age is where we're looking at those sleep-related deaths. Unintentional injury, youth suicide, and youth violence is a newer panel that's kind of a subset of homicide that is happening in the context of youth violence, and often both the perpetrator as well as the victim are under the age of 18. And so we put together a case, and then we have panels for each of these topics, and the panelists come together 1 time per month for 2 to 4 hours to review cases. And so a case gets presented, the panelists discuss that case. Sometimes people have additional information to bring in, or they have questions that need to be clarified. And then that team is going to identify risk and protective factors and draft recommendations that can be taken forward. And we also enter our data into a national reporting system. That's the NFR-CRS, and that's a resource for our state as well as for researchers nationally who are doing research on child fatality. And then on an ongoing basis, we're compiling those recommendations, doing advocacy work, and we publish an annual report. And so confidentiality is a key part of a panel meeting. All members sign a confidentiality agreement. Nothing that is discussed in the panel is ever discussed outside of the panel other than recommendations. And that's always done in a way that's not connected to particular cases. And also these can be very difficult events to think about and talk about. And we always talk about trauma-informed care. The people who come to the panels, we all agree to do the work together and to support each other just as people and in compassion for the families and for ourselves in the work that we're doing. And as I mentioned, these are, this is what a case presentation would look like. These are some of the records that we would be drawing information from and presenting. And then the group is going to try to identify those risk factors. And again, we're going to, we may be discussing, individual behaviors in the event of the incident, but we're going to keep expanding that lens and think about risk and protective factors that could either be mitigated or be enhanced to prevent deaths in the future. And every review also includes a preventability poll. Could the death have been prevented? And I know I've been participating on the SUID panel before I accepted this position that at least with the sudden unexplained infant deaths, around 90% of those deaths are determined to have been preventable. And I would expect that rate's high in all of the panels. And so some ways that panelists can implement recommendations is that they can promote recommendations within their agency, different affiliations, associations that they may be part of, or in their community, and particularly potentially with government representatives or elected officials. Communities can convene work groups, a person could write an op-ed. And so those are individual actions that panelists take and in coordination with the CFR. And then at the state level, we do presentations, we do the annual report. Different entities of state government might convene work groups, implement policy recommendations, or engage in prevention programming. And something like that has happened in our state with the sudden unexpected infant deaths. In one of the in that panel, it was determined that making portable cribs more accessible to families could help mitigate the risks of infants sleeping in unsafe sleep spaces. And so that there was a program was developed, there was a media campaign, and I don't know the number of portable cribs that have been distributed, but I know that it's in the thousands and maybe even bigger than that. I'm sorry, I don't actually know that number. But that's just one way that the work of panels can make a difference. And then I think I just have 2 more slides. And just to say too, that in the effort to prevent deaths, the work also helps to prevent injury. And this slide just shows the non-fatal injuries in New Mexico in 2023. And there were over 1,000 hospitalizations, 6,000, more than 6,000 children who were taken to hospitals, treated and released, and then many more treated in urgent cares or doctors' offices. And so the work that's done can also help prevent these injuries. And then this is our team at the Office of Injury and Violence Prevention. I'm going to turn it over to Carrie to talk about that.
Yeah, thank you, Lisa. My name is Carrie Virtue, and I'm the Injury Prevention Unit Manager in the Office of Injury and Violence Prevention. And this slide shows the different programs we do to prevent things in the community, like adult falls, childhood injuries. Lisa's been talking about the Fatality Review, gun violence prevention. We have gun locks available for communities to distribute, sexual violence prevention and suicide prevention. And all of these people help with the panels as well, right? So we have people from our suicide prevention program working on the suicide panel. And it's really kind of a braided approach to trying to address the child fatality. And if you think about like shared risk factors, something like growing up in a family with domestic violence or substance misuse is a risk factor that often can influence any of these things, right? So we try to address these risk factors together in our office, and also we try to promote what are protective factors, and if you think of like protective childhood experiences, like growing up in a supportive family, a supportive environment, those can really help protect a child as they move out into the world. I know that the work that you do is so important, and the Department of Health, we're always so grateful for this Alliance of Health Councils and the partnerships that many of you have done with the Department of Health. And I think, I don't want to speak for Lisa, but we would love it if any of you wanted to be on the panel, and a panel, and if you could reach out to us and let us know if you're interested. And it's not easy work, as Lisa mentioned. It can be a bit intense, but it's so important. And one child death is so impactful in people's lives. And I don't know if there's any questions. If anyone has any questions or thoughts, but if you want to participate, please reach out to Lisa. She put her information in the chat.
And feel free, if you don't want to participate yourself, if you know someone who you think might be interested, please help us make those connections too.
Great, thank you so much. Is there any, sorry, go ahead.
No, I was just going to say thanks to David. He's leaving.
Okay. Yeah, thank you both for presenting this data and information and invitation to join you. I will again put all the contact information in Monday's email and in the Health Council Hub. And also, if you would like to reach out to Lisa or Sharon, they shared their emails in the chat as well. We have a few more minutes. Val or Geraldine, did you want to add anything?
I think I'm good on my end. I just wanted to say thank you again to our presenters, Sharon, Lisa, and Carrie. We are forever grateful for partnerships, and including health councils and thinking of health councils. The last thing is we are doing our comprehensive survey. We will be sending out the gift cards, and we are extending the deadline until July 30th. So if you haven't had time, we provided maybe an extra week. So if you have questions, I'm happy to hop on a call or Zoom, just to give any clarity. So thank you.
And our next Health Council talk is August 1st, and we'll be joined by Michael Martinez from a fostering family program. So thank you again, everybody, for joining us and for presenting, and we'll see you again soon. Thank you.
Thank
Bye.
you.
Thanks. Bye.